every sign on script base. And certainly when we tried to book them last.
The background noise was me, by the way. I've got 3 PLTs running at the moment and I'm trying to control all 3 of them. So hopefully I've got the GPs on mute now, so we should be all right. Nice turnout, by the way. Thanks, everybody. It's certainly looking good. Due to start very, very shortly. So many thanks.
Hi everyone, I'm just going to give it one more minute for any people that just having a struggle with joining, and then we'll make a start.
Hi.
Hi, we'll make a start then. So thank you everyone for coming today. Appreciate your time. So we're just going to do a bit of an update on the Access and Recovery Programme in regards to the community pharmacy referral update. So my name's Olivia Williams. I work in the primary care team at the ICB and I support some of our practices and PCNs. Minnie, did you want to introduce yourself?
Hi, my name is Minnie Satish and I work for the medicines management team in the ICB as pharmacy integration lead. Rita, I think, is struggling to get into the meeting. We were going to be joined by a colleague from the LPC as well, but let's see if she's able to join, otherwise we'll make a start.
Thank you.
Rita's in the meeting and she's got presenter rights. So Rita, you can take yourself off mute. You should be fine.
Fine. Hopefully she's able to do so. If not, we'll make a start, and if she can join, then great. And if not, then no worries. So we just wanted to sort of start and get a bit of an understanding within the teams of how well do you know your local pharmacy. So it's a bit of a couple of questions we just wanted to sort of ask the teams. I know that you've not got your rights on to unmute yourself, but if you have got the chat function, that would be really great to sort of understand what's people's knowledge and understanding of community pharmacy. So there's a couple of questions we just wanted to ask. So firstly, it was, do you think your pharmacist can prescribe antibiotics, yes or no? So I'll just give people a couple of seconds if they can just respond.
A lot of yes there, Olivia.
Yeah, perfect. Thank you, everyone. That's really great to see you can use using the chat function and interacting as well. Great, thank you.
I like one answer which says in certain circumstances, so that's great.
That is, yeah, and we'll go through that a bit later as well in regards to that answer. That's really good. So second question is, can pharmacists diagnose minor illnesses? So again, just have a quick fire, yes or no. Yeah. Again, insert himself. Then one of the last questions is, do you think pharmacists have COVID-19 vaccinations, yes or no? Yeah, again. It seems like people have got quite a good understanding of what you can. So this is a bit of a bonus round, and again, this might not might not know. So again, does anyone know how many put A, B, or C? So A, apprenticeship, B, and C, yes. Oh, I can see there's a sound problem. Oh, Minnie, I'm just going to mute you and see if that makes a difference. Is that working better for everyone? Yeah, okay, fine. Well, I'll just mute and unmute between us, Minnie. Fab, lovely, thank you. So yeah, we just wanted to do that as a quick fire round, really, to sort of get people's understanding of how well do you know your community pharmacy and sort of what they can offer. So we just wanted to go through the NHS long-term plan in a quick video. So I'm just going to share my screen. The sound should hopefully come through, but if it doesn't, if you can please let me know.
Big changes are taking place across the health and care system. What does this mean for the organisations that make up the NHS? How will they collaborate with other parts of the system? And what will these changes mean for you and me? When the NHS was set up, it focused on treating single conditions or illnesses. Since then, our health and care needs have changed. More of us are living longer, and many have multiple conditions that require regular, ongoing care. However, this hasn't been reflected in the NHS's structure, a patchwork of organisations that often work independently from one another. Navigating this can be confusing and can have a negative impact on our experience of care. So, for some years now, health and care staff and leaders have been working to bring organisations closer together to better meet our needs by working in a joined-up way. Primary and secondary care, social care, mental health and community health services have been seeking to partner with each other in different ways. At a very local level, GP surgeries have been coming together to form primary care networks, groups of practices working together across areas called neighbourhoods. By sharing resources and working closely together with other local people and services, they can provide a wider range of services than a single GP surgery. Health and care organisations have also been working together across larger areas called places, often covering the same area as a local authority, where large parts of the NHS budget are spent. Here, local government, charities, residents and NHS partners can work together to understand and meet local health needs. But previous laws have prevented services becoming even more joined up. The 2022 Health and Care Act aims to change this and make it easier for organisations to work together. But what do these changes look like? Organisations are now coming together across even larger areas to form integrated care systems, partnerships of health and care organisations that plan and pay for health and care services. There are around 40 integrated care systems across England, and although they've existed for some time, the Health and Care Act gives them legal status, as well as new powers and responsibilities. Integrated care systems are made up of two parts: integrated care boards and integrated care partnerships. Integrated care boards decide how the NHS budget for their area is spent and develop a plan to improve people's health, deliver higher quality care, and better value for money. Integrated care partnerships bring the NHS together with other key partners, like local authorities, to develop a strategy to enable the integrated care system to improve health and well-being in its area. NHS trusts are also coming together to form provider collaboratives, new partnerships that can bring together providers such as hospitals, mental health services, and community services. So how are these new structures funded? Integrated care systems get most of their money from NHS England, which is the national body for the NHS in England, and sets the operational priorities for the health system. It's responsible for the health services you and I access day to day, which are inspected and regulated by the Independent Care Quality Commission. The Department of Health and Social Care sets out what the NHS is expected to deliver for the money it gets from the government, which comes from our taxes. It also holds budgets for some of the other areas that have an impact on our well-being, like public health. Throughout these new structures, local authorities play a key role. They receive money locally and from national government, which goes towards funding a range of services that support our well-being and prevent ill health. So, what does this all mean in practice? The Health and Care Act has put in place a legal framework that enables services to work more closely together, so it's easier for you and I to receive the care we need, when and where we need it. For these changes to succeed, staff and local leaders will have to work with one another differently, alongside key partners in local government, the voluntary sector, and communities themselves. Of course, services face other challenges like workforce shortages, growing waiting lists, and the impact of the COVID-19 pandemic. While the new structures won't fix all these issues, by enabling services to work more closely together and join up services for patients, it's hoped that the health and care system will be better able to meet our changing health and care needs in the future. Find out more about how the health and care system is changing at www.kingsfund.org.uk/explain.
There we go. I'll hand over to Min.
How does the NHS in England work? What organisations make it up, and how is it changing over time?
I think the mute hasn't gone away. Yeah, thanks, Olivia. Thank you very much. So that was just to give you a background of what the NHS long-term plan is, and you would it was on the basis of this that the PCNs were formed, where GP practices came together to form little groups so that they can deliver healthcare better for patients. So that's just a quick overview. If it was too fast, if the link is always there, you can go back and have a look. And this is to make sure that we deliver needs for patients at a very local level. And next slide, please. So post-COVID, after the PCNs and everything were formed, things were in a bit of a disarray at that moment because there was a lot happening. And I think when we reference things, we always reference pre-COVID and post-COVID. So similarly, the Department of Health and NHS England wanted to have a stock take of what's happening with the NHS and which direction we need to move forward after the COVID crisis. So they gave this big task to GP, Professor Claire Fuller, who is a practicing GP since 1995, and she was the chief exec of Surrey ICS at that point. And they asked her to look at the next steps of how the PCNs will work in an ICS via the stocktake report. So the report is named after that Fuller stocktake report. And one of the observations that Dr. Fuller made was that community pharmacies kept their doors open throughout the COVID period, and they participated collaboratively with the COVID vaccination program alongside GPs. And Dr. Fuller came out in that report to say that we've got 4 organizations as pillars for primary care, which is general practice, community pharmacy, dental, and optometry. And I think all these pillars need to work in a very coordinated way for primary care needs to be met. So the main recommendation was that the primary care needs to be enabled at the neighborhood point. There need to be single systems where teams are working closely together to make referrals to appropriate places for patients, because as we've heard, one sector alone cannot take up the demand of the patients. Following this, we had more recently a government commissioned Dr. Darcy report, which was investigations of the NHS following the election. Dr. Darcy is a surgeon from Imperial College London, and he was also the Undersecretary for the Department of Health between 2007 and 2009. He did a quick investigation and submitted a report, and the findings were quite similar to what the Fuller Stocktake report was, that the NHS is facing unprecedented demand for care. We've got pressure from an aging population. We've got high levels of long-term illness and long-term conditions. And seeing patients, the NHS was seeing more and more complex patients and trying to meet the needs of these complex patients. And in some areas, long waits are being normalized. So those were his key findings. And his recommendations were to invest in community pharmacy and primary care and use the patient data more effectively so that we can improve the flow and care delivery through, digital if needed, through NHS apps or AI and technology, etc. Next slide, please. We had the PCARP, or the delivery plan for the Access and Recovery program, for the last 2 years. I'm sure you must have heard this word in your clinic catch-up meetings, people referring to the delivery plan for Access and Recovery. So in that plan, there was a pharmacy element to it, and the key services identified as part of that for delivering access in primary care was the contraception service, blood pressure check service, pharmacy first service, and improving digital infrastructure. And more recently, I think we've got the operational report, which will be coming through soon for 25-26 going forward. And we cannot see that these elements are going away. This is going to continue. All these work streams and the focus to shift patients to care where it can be met in other sectors is going to continue. Next slide, please. So the key word here is collaboration and referral to the right care. So from the slides I have previously discussed, to sum it up, NHS is not as simple as it used to be when it started. Patients are more complex. Organizations cannot work in isolation and need to join care to meet the health and social needs. We need to work collaboratively, and referral to the right sector is important, and this includes community pharmacy. And we need to be digitally savvy to do these referrals at a neighborhood level. We need to have good networks and working relationships and flexibility as well with this. Next slide, please. Now, I've got a little example here, and probably really appreciate people putting their hands up, or if you want to type your answers, that's fine, but it'll be nice if we could make this more an interactive session. So there's this case scenario which I'd like to run by you. So we've got a Mrs. Smith. She's a 57-year-old lady who works in a coffee shop. She's generally quite healthy and gets on by herself, and she does all her stuff by herself. She's not on any medications or got any chronic illness, but she's on HRT for her menopause symptoms. she develops some tummy ache, burning sensation when passing urine. So she's got some urinary tract infection symptoms, and she kind of realizes that Friday evening that it's getting unbearable, and she goes to a GP, rings the GP practice, and of course it's too late by Friday evening for getting appointments, so there's no appointments available. So the GP practice turns her away. So what I would like for us as a group to discuss is what are the potential impact of not getting seen at the right time and the right place for this in terms of the practice, your pressures and what happens to you, in terms of the patient, what options the patients have, and probably how it impacts the wider picture. It'd be great if somebody could put your hands up. I can try and have a look to see if any hands are up. Ah, well done. We've got somebody from Albany House. Preeti?
Attendees' microphones are disabled, so you have to type into the chat.
Okay, so are we not able to enable the mic then?
I can do, but then we're just going to have to rely on everybody making sure that they keep their mics off so that we don't get background noise.
Okay.
Your choice. You've got 200 people in the room.
Okay. I think I'll trust this group, and I think I'll go for enabling their mics.
No problem. I'll do it now.
Thank you. Thanks, Craig. Preeti, are you able to speak?
You can come off mute now and use your microphone.
Thank you, Craig.
Sorry, what was the question again? Was it what could the possible complications be for the patient if they weren't navigated to another service?
Yeah, so what is the potential impact if this patient's not seen Friday evening by the GP practice because you don't have any appointments? What are the implications for the practice? What are the implications for the patient? And what are the implications for the wider picture? It's just a fun question.
Okay. Yeah, no, so possibly the patient's symptoms could worsen if she has got a urine infection, which could spread to the kidneys, could cause back pain and further complications moving forward for her. She could possibly put burden on the A&E service because she may well present to A&E, which could have quite easily been dealt with at pharmacy level. And for the practice, it's not utilising the services available for us, where the patient could have been signposted to go and speak to her nearest pharmacy.
Yeah. Can you think of a wider picture as well, apart from the NHS, how it can, because there can be wider implications. I can see a lot of chat activity as well, so that's good. Patient gets worse, extended access for pharmacy refer. Yeah, I agree with all your points there. There could be lots of implications. We'll tell you later what actually happened to the patient because this is a real case scenario. So in terms of the practice, the patient would have obviously got worse. They're going to complete their appointment details for Monday, and you would probably end up giving an appointment for Monday morning again for this patient if she kind of still insisted she wanted to come back to you. And again, practice would have lost an opportunity for giving that appointment to another patient on Monday who probably needed it more urgently as well. In terms of the patient, it would have been a really bad patient experience for that person. She would have suffered throughout the weekend and probably on Monday needed to be seen in a worse condition, like you mentioned, could have had a kidney infection and probably needed more stronger antibiotics, which is not ideal. And then, or could have gone to A&E. So probably A&E would have had another queue there. And she would have to probably not have gone to work as well on Monday. She would have probably had to take time off on Monday because her symptoms were worse and she had to attend the GP practice appointment. With regards to the wider picture, one, the A&E is going to be, or the urgent care is going to have another extra patient. The second thing is the community pharmacy could have easily seen them and they would have dealt with it on the same evening. Imagine this patient I mentioned, she works in a coffee shop. So she doesn't go to on Monday to work. They have to obviously ring an agency or get another person into the shift who probably has to be paid more because it's urgent. You all know that organizations, national insurance has gone up now. So probably that organization, if it has a couple of more individuals not turning up for work, it's going to be quite expensive. And if it's a small coffee shop, probably it's not going to stay in business for a long time. It's going to shut down its business, and probably there are going to be implications for that family as well. So this is like trying to say that, you know, it can have wider impacts than what we recognize or what we perceive. So what you do in your practice in that reception spot or in your admin role can have implications much beyond what we think, and your role is really important. That's the bit I wanted to mention. What actually happened to this patient, I think Olivia will bring in the slide. This is a real case scenario. So what happened is this patient, she rang 111 that Friday evening to say that she's got these symptoms and can't see a GP that day. So they directed her to the community pharmacy first service. Of course, 111 can do that as well. And she got seen by a community pharmacist. She was eligible for some antibiotics. She took that, and by Saturday, Sunday, 2 days, she got rest and recovery along with antibiotics, and she was fine by Monday morning, and she got back to work. So it was a happy ending to the story, but it could have potentially gone bad. And it could have got better as well if the GP practice had kind of directed her to the community pharmacy. We don't know the reasons why that didn't happen, but of course that would have been ideal. This is a real case scenario that happened in Northamptonshire. So this was brought to our attention, and hopefully this will kind of make us think as to, you know, what kind of implications our actions might have in the future. Thank you, Olivia.
Thank you, Minnie. I'm just going to mute you now. So we just wanted to sort of go over what that whole sort of scenario does, and it's ensuring that by having the patient go to the right place at the right time, this does reduce pressure on all the different services for different reasons, as Minnie sort of covered, but it can reduce pressure on the hospital, the pharmacy and the GP surgery for different reasons. So it's looking at the wider picture of this all, that each sort of each patient interaction can have a different outcome of the pressure and where that should really go. And it's using the right service. So there's an array of different services within our NHS. So, and there's different outcomes and different things that we can sort of signpost patients to. So obviously we've got the self-care, looking after yourself at home, the pharmacy, which is obviously what we're going to go into in today, 111, GP practice, urgent care, and A&E and 999. So there's 6 different sort of pillars here that we're just sort of putting as a one-stop slide to you to have a look at. But each one of those has different things that can be looked after and the patients can go to. But it's ensuring that these patients go to the right service, because by seeing the wrong one, it can sort of have a knock-on effect and a domino effect on the different services and the patient's care and their pathway of that service. So there's a few things we wanted to sort of touch on this training session this afternoon. So we wanted to go over the current community pharmacy services. So there's sort of 2 pillars of this. There's the essential service and then there's the advanced service. So the essential service is the mandatory services that's for all community pharmacies. So that will be your things like your discharge medicines, your dispensing, medicines waste disposal, the healthy living and public health. So that will be sort of your general pharmacy that all community pharmacies will be doing day to day. And then there's the advanced services. So these are the bits that we're going to sort of highlight today. So these are not mandatory. So the pharmacies need to sign up if they want to deliver this or not. And there's loads of different things that they can kind of cover within that. So some of these you'll be sort of aware of, which we brought up earlier. So for example, the COVID and flu vaccinations and things like that, smoking cessation, But the things we want to discuss today is pharmacy first, which includes the 7 clinical pathway and the minor ailments, which was previously CPCS, the hypertension case finding service, and then also the oral contraception service. So they're the sort of 3 ones that we've highlighted there that we're going to go through a bit further. So yeah, it's just to sort of understand that there's the essential and the advanced services. So firstly, we've got pharmacy first, which is the first one we're sort of going to go through. So pharmacy first is sort of an umbrella term, and under that there's sort of 2 aspects of that. So there's the new advanced service, which includes the 7 new clinical pathways. And then there's the minor ailment service, which was previously community pharmacy consultation service, or CPCS. And you may be you may sort of have a bit of an understanding or knowledge on that, because CPCS has been going on for a few years. So there's sort of part A and part B. So A is the previously CPCS, and then B is the clinical pathways. So that includes the 7 clinical conditions, and that's the new element of it, which we'll go through. So within Northamptonshire, we've got 123 out of 125 of our community pharmacies that have signed up to deliver this. So that's a really good sort of really good amount of pharmacies that are covering sort of all our patch. And those 2 pharmacies that are not signed up are distance selling pharmacies. So that's why they've sort of not started in this service. But yeah, so it's a really good coverage within Northamptonshire. So I just wanted to go through sort of the patient pathway of accessing pharmacy first. So the patient will visit the practice, so they'll contact yourselves. This could be on the phone, this could be online. I know now a lot of practices have the triage system as well. So that could be however the patient contacts the practice. And then the practice will then refer the patient into the pharmacy through the appropriate route if they're eligible for the service. And then there'll be a number of outcomes that can come from that. So we'll go through that later on in through the slides, but they've just listed there. So we've got self-care and medicine, and refer to another service, or refer to a higher care. And then the practice will then be informed of that outcome. So they'll receive the post notification to be aware of the full circle of that. And then if needed, the patient can be escalated back to the practice if needed, if they're sort of hitting those red flags. So I'm just going to hand over to my colleague Rita. Hopefully you've got on all okay. And I'll just turn my mic off.
Okay, can you hear me? Just a thumbs up from Olivia would be great. Okay, perfect. Hello, everybody. First of all, I'm sorry we had some IT issues at the beginning. So Craig, thank you very much. Also, we didn't get to say hello to you properly. So my name is Rita. I am a pharmacist by professional, but I do a lot of work with the ICB, and I'm not sure what the introductions were earlier, but I just wanted to give you some background. So myself, Olivia and Minnie, we've done quite a lot of work since October 2024 on Pharmacy First. And when I was looking down the list of names of people that are attending today, I actually recognised quite a few of the reception teams and some of the surgeries. So it's really good to know that some of the surgeries we've done quite a lot of work with are actually on this group. So first of all, thank you for your time, because I know 2 hours is a long time. We're going to try and make it fun. Well, Ricky and I are going to make it fun. Minnie and Olivia, maybe not so much. So Minnie, Olivia have spoken about Pharmacy First and how it aligns with the broader NHS plan. What Ricky and myself want to do is we want to bring it back to what does it mean to you in practice? So if you have any questions, there is going to be a session at the end, but please then do put things into the chat box as well. So why is this service important? The 2 groups that we're looking at mainly is patients and GPs. For patients, the first thing that we need to say is that it's about getting timely treatment, timely appointments without any delays. Not saying that you won't do that through the GPs, but if there is a way to access a pharmacy within the first 12 hours, then absolutely, they can use the pharmacy first route. So that's number one. Number two was about health education. So when they come into our pharmacies, we can also talk to them about self-care and other elements that we can help them with. But the most important thing is about educating Joe Public that there is another healthcare professional out there who they can go to, not just for minor illnesses and the 7 clinical conditions, but a whole array, as you did the quiz earlier, that pharmacies are so highly skilled. They are so much more skilled than dispensing prescriptions, which I know most of you will know. So this is about educating the Joe Public that actually you do not have to run to the GP surgery all the time. If we move on to benefits for GPs, absolutely, it's obvious it frees up appointments, but hand in hand with that is not just the freeing up of the appointment, it's allowing the complex patients to then be seen again in a timely manner. So the two go hand in hand. When we've done some of the pilot work, and I know 1 or 2 of the surgeries are on today, one thing that's come through, a couple of the surgeries went live in November. And when we've picked up with them in January, one of the things that they told us, and it's a real benefit, is that there's been a decrease in footfall into the surgeries. So this is both phone calls online and just patients coming in to say that they need to see a GP. And I know as reception teams that are on this call, that has to be a positive. So the decrease in footfall is definitely one of the key things that hopefully Pharmacy First will enable. And the other one is collaboration. The one thing that we've really enjoyed, and Ricky should talk about it as well, is that it's about working with GP surgeries and the community pharmacies. It's about having a more integrated healthcare approach, and it really does help with the patients, absolutely, but it also helps with the 2 sets of professionals talking to each other. So that is why the service is important. Next slide. Whoa, I'm not going to cover every point, otherwise we will be here to 3:30. So, like I said, we've done lots of work with reception teams. One of the key messages that I want you to take away from this slide is the common question we got told and asked all the time by receptionists, and even now we get the same question, is why can't I signpost? Why do I have to do 20 clicks on my system 1 on my EMIS? Why can I not just signpost that patient to go to the pharmacy? And the key message there is when you signpost, there's no track of what happens to that patient. Basically, that patient goes into a black hole. You don't know if that patient went to the pharmacy. You don't know if the pharmacist saw that patient. I know it sounds really obvious, and I know it's so easy just to say to that patient, and we have the same when we're in pharmacies, to signpost them elsewhere. But the whole reason that the NHS put together Pharmacy First was that you would have an audible trail. So when you refer formally, and yes, there's about 7 more clicks, and some of you are going to put in the chat, it's more like 20 more clicks. The actual positive that you get out of that is that the pharmacist, number one, knows that the patient's coming in, because they also have 100 things going on. When they know the patient's coming in, they will put 1-to-1 consultation time for that patient, not over the counter in front of other patients, but in a consultation room, and that patient will get a 1-to-1. Also, it's a trail. So when the consultations completed, the GP surgeries in all cases will get a post-event notification so that the GPs know what's happened to that patient. And absolutely, that's crucial, especially if you have repeated incidences where that patient goes in. So even though I know signposting is a quicker option, the actual formal referral leads to better care for patients and, more importantly, better visibility for the GP practices. So there are other points, and we are going to share the slide deck with you, but I'm just trying to keep it top line for the slides. Next slide. Okay, so Olivia's actually gone through this. This is how do I refer patients. This is not how many clicks do you do on System 1 or EMIS. And I know Olivia's done this already, and apologies in advance because all of us are repeating some of the key messages from one to the other. So I am sorry. But again, very simply, the top line is what Olivia's gone through. Identify the patient, refer the patient either on System 1 or EMIS. The pharmacist then does the consultation, and Ricky is going to talk about that in a little while. And then the surgery get a post-event notification, and that is normally on the same day, but within 24 hours. So there'll be something that comes back to the surgery. I know a lot of you, and I'm hoping you're asking the question, that means there's more work for us at the other end when the notification comes in, but we can talk about that later. The bit that I want to talk to you about is we've done lots of work with surgeries, and the one thing that kept on coming back, and this is from the GPs, not from the reception teams, is that when there's an escalation, when there's a red flag, or some people call it a bounce back, what happens to that patient? And the feedback we got from GPs is that they felt the patient, again, went into a black hole. So the patient's being sent to the pharmacy formally. We've done the consultation. However, there was a red flag and that patient needed to come back in. In the past, what's happened is we tell the patient, go back to your GP surgery. And in that process, there's loss of communication. And before you know it, that patient's inside your reception area, screaming, shouting, we need an appointment because the pharmacist has told me that I'll die tomorrow if I don't see the GP. So what we've actually done is we put a process together where we have a backdoor telephone number. So, and it's worked with all the surgeries we've worked with so far. You have a backdoor telephone number. So when there is a red flag of an escalation, the pharmacist rings the backdoor telephone number, speaks to one of the HCAs or the practice manager, whoever's on duty on that telephone, and they work out between them what the best route is for that patient. So the patient gets seamless end-to-end care. And that's the part that I wanted to bring up on this slide, mostly. Next slide. This is a slide that's come in last minute because we got a complaint from a GP surgery over the past couple of weeks. And the only things that I need to point out is, and you may not know this, so in surgery world, there's two IT systems, System 1 and EMIS. The way they do pharmacy first differs only in how pharmacies get that referral. If you are EMIS, which is the easy one, it's integrated and it goes into Farm Outcomes, which is a portal in pharmacy that we use day in, day out, all throughout the day. When the referral comes in that way, we get to pick it up very quickly because we're on that portal. If you use System 1, the referral can go one of two ways. It can either go through Farm Refer, which is brilliant because it goes into Farm Outcomes. The benefit for the pharmacy is that we see that referral very quickly and we can act on it quickly. However, many of you are using the Ardens template, and that's not a problem at all. We know it's something that you're more comfortable with, and it's not a problem because pharmacies can put processes in place to actually pick up their referrals. The only issue when it comes in on Ardens template is it comes into our NHS mailbox, and the specification clearly says that that mailbox only needs to be monitored twice a day, morning and evening. So occasionally that referral may get lost. However, if you guys are working with the Ardens template and we communicate to the community pharmacies and we can support you, I can support you with that communication process, then we'll make sure that the pharmacies are picking up those emails more regularly throughout the day. However, while we are finding our feet with that, the best way forward is when you are talking to the patients, and you guys are the key to success in a way, because what you tell the patient needs to be so clear so that they know where they stand and they get a real seamless end-to-end care. So the norm, and we can help you with wording. There's lots of templates from NHS England. I know they're on the ICB portal, but we can help you with wording as well, because that is one of the feedback that we got from the reception teams. But what we're asking you to do is say, A, the pharmacist will contact you with X number of hours. We're sort of working between 4 and 5 hours. But just to cover yourself, we would like you to say, we're going to give you the pharmacy telephone number. And if you don't hear back from the pharmacy in the next few hours, please feel free to call the pharmacy. I'm not going to ask for feedback on that, but if you would like to put any questions in the chat box, I'm going to pass it on to Minnie to answer them. Next slide, please. Am I going too fast? You can put thumbs up from the audience if I am. No, perfect. Again, don't want you to read the slide. This is about inclusion and exclusion criteria for both minor illnesses and the 7 clinical pathways. The reason we brought this up today is just to let you know that during the pilots that we did in some of the surgeries in Northampton, what they found really useful is to print off these inclusion exclusion criteria and just put them by the reception phones in the morning, just to make it easier. It's only for the first couple of weeks. It doesn't have to be there all the time, but the first couple of weeks, 8 o'clock in the morning, the practice managers or reception leads would put these copies out just so that it's a bit of an easy guide for the reception teams to do. All the resources are on the portal, so I'm sure Olivia will speak about the portal in a little while, but that's what this slide is. Very quick, very simple. Next slide. Oh, whoa. Okay, so I keep on telling you about all the work we've done with the surgeries in the past few months. And what's happened is the world of GPs has changed. Before, the patients would either come into the surgery physically or call the surgery. And now there's the introduction of the triage system. So we have about 4 or 5 amazing surgeries out there in Northampton who have started pharmacy first back in October, November, and put processes together for both System 1 and EMIS, and for both triaging surgeries, online platforms, and even those where patients still just come in, or even a mixture of both. Again, please don't read this slide. The reason we're bringing it to the table is to say we have that resources. As surgeries out there, you don't have to reinvent the wheel. There are processes that have been put together by other surgeries that work and work really well. For example, I think it might be the surgery that did this process. In November, December, they did 80 to 85 referrals of Pharmacy First in 1 month. So that's 80 to 85 GP appointments freed up so that GPs in a month can look at more complex cases. So that's the only part on this one particular slide, is to say there are resources out there. If you can't find it on the portal, please come to us. One of the reasons that we're doing today's training is so that you have a face to the names that you might be talking to when we email you. We're here to support you, so please do shout if you want any processes that might help your particular surgery. Next slide. Okay, so there's always questions. I'm just going to tackle the first couple of questions. I can't read the first one. I think I wrote it out. Will GP practices be notified of the consultation? Absolutely. We've spoken about that a couple of times, and I think Ricky will touch on that as well. You will get a post-event notification. If you want to know the detail of how and where and what do we do afterwards, then we can pick that up as well. But yes, you will get a post-event notification. Question 2, can pharmacies deviate from the clinical pathways? No. We have strict guidelines. We cannot deviate from the clinical pathways, and that is so that we have safe and consistent care for the patients. And the third question, do patients have to pay? that depends on what the outcome is. If the outcome is an NHS prescription, NHS medication, then the normal rules that would apply to that patient in terms of prescriptions, if they're over 65, etc., whatever rules apply, that's what they would apply in that case. However, if the outcome is an OTC product, over-the-counter product, then yes, the patient would have to buy the particular product. Okay, next slide. Okay, so I'm going to introduce you to Ricky. Ricky is superintendent for the Sage Pharmacy Group. Now, the reason we've asked Ricky to come on is when we were working with reception teams and GP practices back in October, November, one of the feedback that we got was, we don't know what happens at the pharmacy. We don't know when we send patient X, Y, and Z to the pharmacy, what actually happens at the pharmacy side. And what we found is when we got pharmacists in, when we were working with these reception teams, to actually go through what happens at the pharmacy, it gave the reception teams the confidence to really say to that patient, go to the pharmacy, we're going to book you in for a one-to-one consultation, and actually be able to, I'm going to use the word sell to the patient, but actually be able to tell the patient confidently that we're not just sending you from A to B, we're actually sending you into the capable hands of another healthcare professional. So, Ricky, all yours.
Oh, brilliant. Thank you so much. So, yeah, good afternoon, everybody. So like Rita said, I'm from Sage Pharmacy Group. So we've been working with a couple of doctor surgeries locally, and we've been collaborating to try and improve the access for patients for the pharmacy first services. At the moment, it's going very well with them. And I think a key aspect of that is just to have open communication with the doctor surgeries, book appointments with them, and obviously feedback any issues that are happening along the way. So today I'll be focusing mainly on the pharmacy perspective of what happens when a referral does come through. So just regarding each one of the 7 clinical pathways, each condition has a robust framework that's set out by NHS England. So it's a crucial part of this framework is the gateway criteria. So the gateway criteria is specific for each condition and has to be met for the consultation to continue. So any consultation that doesn't meet the gateway criteria will go onto another pathway. So for example, if a patient presents with symptoms such as shingles, but after the initial consultation, the pharmacist suspects that it could be another type of skin condition, the criteria for the shingles will not have been met and the consultation will continue under a different pathway. So that's very specific to each condition. So if the gateway criteria has been met, the consultation continues under that specific pathway and the appropriate outcome is determined. So I'll touch on the different outcomes that can happen a little bit later on, specifically with the condition of UTI, just so you can have active examples in terms of how we do with the outcomes for each patient. So I want to emphasize the importance of ensuring that the patients that have been referred over to the pharmacy do meet the inclusion criteria, and having like a structured A4 sheet with the inclusion exclusions on there for the reception staff to quickly have a glance at is very useful. So there's a lot of information out there, and we can supply that information to you as well, so you can have it printed and put up at reception desks. So one example was that when I was working in one of the pharmacies previously, we had a patient that was referred from the doctor's surgery for a UTI. So the patient unfortunately was over 65, so it actually disqualified her from the service itself. So unfortunately we couldn't proceed with the consultation, and we had to refer her back to the doctor's surgery. So the situation not only impacted the patient's experience, but also created some uncertainty. So potentially, like previously we had a UTI example, the patient could have gone home, experienced more symptoms, been referred to the 111 services, and caused quite a lot of complications and impacts for the patient ongoing, and also loses confidence. The patient loses a bit of confidence within the NHS structure and the services being provided. Yes, I'm ready for the next slide. Perfect. So as you're aware, when a referral is sent to the pharmacy, it's often sent by NHS email. So some pharmacies may not always be in the habit of checking the NHS emails. Now, with the pharmacy I'm working at the moment, we are getting a lot of referrals from the doctor's surgeries. So therefore, we are in a very regular habit of checking emails every 15, 20 minutes just to make sure that we haven't missed any referrals that come through. So there can be sometimes delays, as I mentioned previously, in checking the referrals and contacting the patients to book them appointments. So initially, when you are setting up the service, if you haven't done it previously, one good thing to do is to make sure you let the patient know, either via text message, on the phone call that you're doing, just to let them know to contact the pharmacy if they haven't heard from them within a couple of hours usually. So once, I think, and the most important thing is setting up a collaboration with the community pharmacy you're working with at the moment as well. And if you're unsure about referring the patient, you can always pick up the phone, speak to them directly, and just make sure they're suitable before you actually send that referral through. So currently at the moment, we receive about 7 referrals a day. So the pharmacist and the staff on duty do check it regularly at the moment. It's important to let the patient know about the wait time, because it's not always done straight away. So the patient might become a little bit anxious and realise that nothing's happened. So always give them a lead time for a couple of hours to follow up. And this way also will ensure that no referrals are being missed as well. So hopefully, you know, if the pharmacy is getting 7, 8 referrals and they've missed one phone call, then at least there's a safety net there where the patient can contact the pharmacy. So when the referral does come through to us, what we usually do is ring the patient. So we just find out a little bit of information from them initially, just to find out what sort of condition they're suffering with, etc. And usually we book them a time slot to come into the pharmacy. So at the moment, we're using systems that are freeing up a lot of pharmacists' time, which has been really, really critical in terms of having that flexibility where we can actually spend 15, 20 minutes with the patient, sit down in the consultation without being disturbed, to go fully through the consultation itself. So with the platform that we use at the moment, some pharmacies may use various different ones, but at the moment we use something called Pharm Outcomes. So this is a platform that allows us to input the NHS number from the patient, which is sent via the GP surgery. We load up the patient details, obviously confirm all the details of the patient, and it's a designated software that's got the templates for each condition on there, and also it allows us to include key information on there, which gets referred back to the doctor's surgery. So the information that we do input on there is the observations we've made, any diagnostic we've done, O2 saturations, blood pressures, any of the symptoms might be associated with it, and also all this is formally documented. So that's one of the main reasons of doing a formal referral to the pharmacy. So the information that we've provided to the patient, all the assessments that we've done, gets sent back to the doctor's surgeries to complete the full cycle. So the other thing is sometimes, obviously, we're not able to deal with all the consultations within the pharmacy, depending on the symptoms they may be experiencing. So having an up-to-date record sent back to the GPs. So if we were to make a referral to the GP, then the GPs can actually see the referrals that we've done, the products that we've supplied, the advice we've given. So before they even contact the patient, 80% of the information is actually already there. So they're aware of the reason that we've actually referred them back to the doctor's surgery. So, I mean, going back to that, we've seen a lot of communication breakdowns. That's why this is very important. So there's been various occasions where we've actually verbally communicated something to the patient. They've gone back to the doctor's surgery and something totally different has been relayed to them. And then we receive a phone call from the doctor's surgery about this misinformation. So, you know, it's a vital part of the service where the information is documented and it can be seen by all. So The clinical outcomes that occur after the consultation for each one of the 7 pathways, I'm just going to talk you through all 6 options that actually are available to us. So there might be a view from surgeries where we can only do one aspect of it, so either a supply or a non-supply, but there's many different aspects that we do follow. And leading from, because we went through a UTI example before, I'm just going to give you an example of a UTI patient and give you the options that are available to us for each patient. So firstly, the outcome 1, so it'd be self-care advice. So if a UTI is deemed less likely, perhaps due to the symptoms being mild or not characteristic of a UTI, the patient will be given self-care advice. The patient, that can include things like pain relief, guidance on how to monitor symptoms. So that's one aspect of it. So the second part is self-care advice with the sale of over-the-counter medication. So if the patient has a UTI but doesn't meet the criteria for an antibiotic, perhaps the symptoms have just started or are mild, or because often here a UTI can be self-limiting, so after a couple of days it might have cleared it by itself. So we recommend.
Have we lost Ricky? I think we may have lost Ricky. Rita, did you want to continue, or do you want me to step in? I can just.
Can you step in? Sorry.
Yeah, no worries. So Ricky, please feel free to come in when you get back online. But I think basically what Ricky was trying to summarize was the outcomes might be different depending on the consultation and further questions that the pharmacist asked the patient. Sometimes when you refer them for the 7 clinical pathways, it can turn out to be just a minor illness condition, and they might advise self-care and over-the-counter medications. The over-the-counter medications is part of the NHS self-care agenda. So they are medications which probably are not very expensive, which patients are expected to buy as part of looking after themselves and cannot always have everything on the NHS prescription. But if they are eligible for the clinical pathways and fulfill all the criteria of the patient group directions, which was built based on the NICE evidence-based criteria, they would get a non-antibiotic product, or they might get an antibiotic product. So one of the important things are when you refer the patient for this pharmacy first service, don't build up their expectation by saying that if you go down to the pharmacy, they might be able to give you an antibiotics, because there are non-antibiotic products as well as part of that supply. So, you're back, Vicky. Okay, go on.
Sorry, a technical issue.
No worries, go on.
Sorry, are you carrying on? You can. I don't mind.
No, I've just summarized that. You've got the antibiotic, non-antibiotic options, and also depending on the assessment, self-care or prescription-only medicines.
Yeah, that's it. So so the next outcome was the supply of the medication. So for patients who clearly have a UTI, so we prescribe antibiotics to them, such as nitrofurantoin, 3-day course. Along with the medication, we'll provide clear instructions on how to take the antibiotics and offer self-care advice as well. Outcome 4, so there's no supply of the medication, so as it's clinically inappropriate. So in cases where it's very mild symptoms, and then the other thing we do is always provide safety netting advice. So if symptoms persist or they become worse, or you have any new symptoms come up, to come back to the pharmacy for reassessment or speak to the GPs. Outcome 5, so it's an urgent referral to the GPs, so or the out of hours doctor services, whichever is more appropriate depending on the time. So this could be reasons because certain exclusion criteria do exist just to make sure there's nothing untoward going on with the patient. So reasons can include recurring UTIs, that can suggest a more underlying condition, certain things like pregnancy, allergies to medication, or suspected STDs. And the final outcome is a routine referral. So with these, with the pharmacy first and UTI, we wouldn't usually use a routine referral because it's something that needs to be dealt with a bit more urgently. But in certain cases, certain scenarios of pharmacy first services, a routine referral can be sent to the GPs, which they'll uptake within 2 to 3 days, contact the patient and deal with the issue that way. So just like I want to clarify, in every scenario that we do, we always ensure that the patient is clearly informed and understands how to follow up. So it's critical to prioritise patient safety and to provide the necessary care based on the condition. So yeah, I'm ready for the next slide. So the data shows that using the pharmacy first services, that 9 out of 10 patients, so 90%, have their episodes of care completed in the pharmacy, thanks to the clinical pathways that are present now. So this means only 10% of patients need to be referred back to the GP. Now, it's important to emphasise that it doesn't mean that the service has failed, but on the contrary, that that it's signs that it's actually working and it's becoming successful. So the referrals that do occur are due to specific reasons identified by the pharmacy during the consultation. So before implementation of Pharmacy First, pharmacies didn't have the ability to supply prescription-only medications, so the majority of patients would have had to be referred back to the GPs, resulting in increased workloads for the GPs and longer waiting times potentially. So now with this initiative, pharmacies can supply a range of prescription medication directly, significantly reducing the need for referrals and helping to relieve the pressures on the GP services. So those pharmacy first patients can be referred to the pharmacy directly, and then the GP appointments are freed up for more complicated, more serious cases, that they can actually have free appointments for and see patients, for other hosts of conditions. So when patients do urgently, when patients are referred back to the GP practice, it's critical that each surgery communicates with the pharmacy in how they want that to be dealt with. So there should be an agreed pathway. So locally, we've got system setups when we can actually directly contact. So at the moment, when we're working in the pharmacy that I'm working at the moment, one of the doctor's surgeries has said, look, we don't want the patient to be in limbo at any point. So they've actually given us numbers to the duty doctor. So we actually do directly ring them, go through the consultation. Obviously, the doctor will have the feedback from the notes we've sent, and then we'll come to an agreement. So either we'll speak to the doctors, they'll get them an appointment book so we can give that information to the patient, or they'll prescribe something that's more suitable and they'll send a prescription directly to the pharmacy. That way, when the patient's there, from the start of the consultation to the end, their full care has been taken care of. Sometimes there's been incidences where obviously patients have to go back home, wait for the doctor to phone. So with the practice that we've arranged a service with, they're happy for us to follow this pathway, and it works very well actually. They're actually increasing the referrals coming through, and by either word of mouth, but the surgery close by, they've been doing a similar thing now, just because they've been talking about it with each other, and they've realised that the service is working. So it's just bringing on more surgeries on, basically. The other way to do it is, so there's another surgery that we work with, and we have a backdoor number as specified previously. So we have a backdoor number, we give them a call, just let them know, look, we've sent a referral for XYZ for this reason, please can you get the duty doctor to have a look at it and give the patient a call. So there's various different ways to do it, but just what's best for the local community that you've got at the moment. To sum up, while only a small percentage of patients are referred back to the GPs, it's a clear indicator that the service is working as it should. With pharmacists and GPs working together more effectively, the partnership enables the patients to receive the right care at the right time without unnecessary delays. I think that's covered everything. So yeah, thank you guys for having me on. If you've got any questions, just please let me know.
Thank you, Ricky.
That's okay.
I just had my hand up just to add a point of some good examples I thought I'll share with the group. So I've heard in different parts of Northamptonshire where the practice is just next door to the pharmacy. Sometimes when the pharmacist rings the GP doctor and lets them know that I've got a patient and for these reasons I can't fulfill the PGD criteria to give them a prescription only medicine, the duty doctor says, oh, just ask them to just wait there in your consultation room. I'll come around. And then they come around and do the rest of the consultation then and there if they are free, and then ask the patients to pick up a prescription if another prescription is required or signpost them. So those are examples where that neighborhood team is working very effectively rather than using formal processes. They come and see the patient and then the GP is still able to go back to the practice and complete the records for the patient consultation. So yeah, I thought I'll just share that.
Thank you, Minnie. So we're just going to have we'll do a 10-minute break just to ensure that we're all finished at 3:30. So if everyone wants to just grab a coffee and go to the toilet, if we come back at 10:02, and then we'll do the next part of our slides. So thank you everyone, and we'll see you in about 10 minutes time. Thanks, everybody. We'll make a start because I'm conscious about time and finishing on time. So hand over to Rita.
Okay, welcome back. Hope you've all had caffeine and chocolate, a bit of a hit. I know I've had a quick bit of tea. Look, we've given you so much information. I feel like we've done death by PowerPoint, plus we've been talking non-stop. So was that death by PowerPoint? That thumbs up. So sorry. So we just wanted to check in, really. Check in. We've spoken at 100 miles an hour, you know, all of that. So just want to check in. How are you feeling today? So as a team. So the first left-hand top is positive, confident, okay, not in a good place. Bottom left-hand is tired, need a bit of a recharge and coffee break wasn't enough. Top right, neutral, understanding what we're telling and what we're saying to you, but not quite sure. And the bottom one, which is definitely me on a Friday night, is energized, ready to go, confident, and going to go back tomorrow and absolutely start pharmacy first. Doesn't have to be about pharmacy first, how you're feeling, but I don't know if we could have some thumbs up or shocked faces if it's one of the negative ones. Be kind, please. Okay. Oh, see, I don't know what that one means, but okay. And you know, perfect. Loving it. Look, we are going to do a feedback session at the end. Olivia will go through that. So please tell us, because we want to listen to you. We're not trying to lecture or any of that. We want to listen to you. We want to work with both community pharmacies and GP practices. And at the end of it, we want to put the patient right in the centre. So please do talk to us. And the other part is we are here to support. You know, I know there was a bit of negativity on the chat about my pharmacy doesn't pick up the phone, etc. I truly believe, and I am old and wise, that nobody comes to work to do a bad day's job. And sometimes it's just one side can't understand the other. So sorry, I'm just laughing at some of the emojis that are coming up. Nobody wants to come and do a bad day's job because it doesn't do anyone any good mentally either. So please do talk to us at the end, fill out the feedback session, and whatever we can do to support you between your practice managers, your PCN managers, your GPs, yeah, we will support where we can. Okay, I think that's me done.
So, so before I start talking through the slide, let's just hear a video recording. We've been working, like Rita mentioned, Olivia, me and Rita have been working with loads of practice managers and PCN managers, name a few, Helena, who've shared some of the resources that they use, Joe Penal and Sydney, loads of them, and they've all kind of helped us learn a little bit more and contributed more. So we'd like to play a little recording of one practice where this has gone really gone in leaps and bounds, so that you hear from their reception team's words. Yeah, are you okay to share that?
Thank you for agreeing to talk to me about Pharmacy First. Before we get started, do you mind just telling me a little bit about you and where you work?
Yeah, so my name's Debbie. I work at Abington Park Surgery and I've been here for 4 years.
Lovely. And are you on the reception team?
Yes, yeah.
Yeah, fabulous. So can you tell me a little bit about what you think of Pharmacy First and how the launch has gone in your practice?
So we've been running it now for about 3 months, and it's really worked out well. We're seeing a lot more patients So we're finding like at the end of the week, we're not as busy as we were because we're getting all the patients seen through the week. So it is working really well. And we've had a lot of really good feedback from the pharmacy themselves. We've got a very good working relationship with them now. We've had lots of meetings with them. We've ironed all the little kind of like things out, and a lot of patients have come back and said how happy they are because we're getting loads more patients seen by them.
Excellent. That's really good to hear that the patients appreciate being sent to the pharmacies. What impact do you think that's had on the GPs in your practice and the reception team? Has it made things easier for you?
A lot easier. Yeah, we're finding that the more complicated cases now can go to a doctor, and then the minor things can go to the nurses, and then the very, very minor stuff like, you know, your normal coughs and colds can go to the pharmacy, and it is working really well that way.
Brilliant. That's really good to hear. And how do you feel it impacts you as a receptionist? If you have to, I take it a lot of your patients now are submitting online requests, aren't they? And is it the GP that actually reviews that request coming through and then will task it to reception to say, please refer to pharmacy first?
Yeah, the doctor has a look at it. He makes the clinical decision, which is better for the patient because it's not the receptionist in the olden days making the referrals to places. It's now the doctor doing the clinical side of it and saying, no, I think this is going to be better seen by the pharmacy. And so it kind of works really well.
Yeah, and that must be good for you to be able to say to the patient, the doctor has said you should go to the pharmacist as well. Yeah, it takes that pressure off you as a pharmacist. That's brilliant. And do you get many requests back from the pharmacy, or do you find that a lot of patients are referred to the pharmacy? They go, they're seen and sorted.
A lot of the time, I would say just over 3/4 are all sorted, but there's a couple of cases that do, by the time that they've gone to see the pharmacy, have got a little bit worse, and then the pharmacist rings the doctor direct or gives us a ring on reception direct, and then we refer it straight back to the duty doctor, and then the duty doctor will get them in here straight away. Lovely.
It sounds like that's a process that works really well then. And you think everybody seems happy with it and it's working well?
Yeah, the amount of feedback that we've had a lot of people saying, well, we were dubious to start off with, but we're being able to see so many more patients in a day and do so many more queries. It's, you know, it is really good, and the patients are kind of like feeling that they're being listened to a lot quicker than what it was before.
Yeah, excellent. That's really helpful. Thank you ever so much for sharing your experience, Debbie. I'm sure that will come in really handy for other practices as well. Thank you.
Yeah. All right.
I don't know if Minnie's internet was playing up, so I'll carry on. If Minnie, if it comes back in, then feel free to take over. So that was just one of the training videos that we've got from a practice and a PCN that were just showing their experiences. And we've also got a couple of other training videos, which we won't put on now, but we'll send this out in the pack of resources to everyone. So those include a System 1 and an EMIS training video. So there's two separate videos, and that's more of a sort of referral process video. So it will explain how to send referrals and where to click. So it's a bit of a how-to guide. We've got both of those videos hosted, which we'll send out to you, but the links are just out. Like I said, I won't send those. I won't play those now, but the resources are there for those who need it.
Thank you, Olivia. I'm back now. Don't know what happened there. I just wanted to make a couple of points while we are on this slide. So EMIS practices, it's embedded. Things are not going to change for the future. So it's live, and it's there's a process for that, and it's easier. You don't have any MFA issues. For System 1 practices, like Olivia said, the video we commissioned this video so that it talks through both the processes. The first one is the farm refer process, and the second one is the Arden template and the nhs.net email process. So we've just in a regional call this week, and I remember that some of the PCN and practice managers, we were discussing for System 1, how lovely it would be if System 1 developed something similar to EMIS, where the referral will be embedded within the System 1, so it can go as a digital referral rather than email and via an external platform with MFA. So what we've heard is TPP, who manage System 1, are going to ensure there's going to be something going live by March, April time, so that the workflow referrals can flow smoothly between System 1 practices and community pharmacies. So the future looks bright in terms of flow and some of the barriers around logging in, logging out, and all those barriers. So for the time being, if you could stick with the nhs.net email referrals, if the farm refer is not the one for you, and we will come back to you with the process for System 1 or TPP at a later date when it's available within a couple of months, not too long, and then we can make the system more easy flowing. I just wanted to mention a couple of other things as well. So with our conversations with the PCNs, we have one-to-ones with PCNs. We are happy for GP practice leads identified. It'll be good if you can go back and find out who your GP practice lead is for community pharmacy services, PCN engagement. So I think they would be the people that we can update, with anything which is developing so quick and fast. And based on these conversations, we had one practice who came back saying that the exclusion inclusion criteria, which of course we didn't design, the national team designed, does not have back pain for UTI as one of the exclusion criteria. And because of that, we are having to refer patients and they're coming back. So that's the second good news today, that we are, the Midland CPCLs, we are reviewing the inclusion exclusion criteria poster. So look out, so we will be including the lower back pain in the exclusion criteria, so you don't have to send these patients. And so we will keep you updated by updating the portal link, which Olivia will talk through in a bit. Somebody mentioned about the total triage model, and that's what you just heard one of the practices talking about. This is the practice where you have these digital platforms, Anima, AccuRx, and these platforms don't automatically pick up on the symptoms which can be referred to pharmacy first. They dump all of those tasks into the GP workflow. So this particular practice have adopted a process. So that's the crucial matter there. You adopt a process where you have a way of identifying which these appropriate ones are, send them away. So from that video, it was clear that they had a process where the GP duty doctor sat with the reception team, scanned, and if they thought that something was more appropriate for pharmacy, they would pass it on to the reception team to make sure that they completed that referral, which has absolutely worked wonders in terms of referral numbers for that practice as well. So yeah, next slide, please. I've got another example here now. So Mrs. Green, so we've heard a lot about the different services. So we've got a lady, Mrs. Green, who's a 70-year-old retired teacher. She's not very well. She's got long-term conditions like diabetes and asthma, and she recently developed a sore throat. So we've got two scenarios here. So we've got a scenario one where GP surgery is picking up that consultation because the online consultation platform, Anima, or whatever one you use, has tasked the GP that this patient needs seeing because she's vulnerable, she's elderly, she's diabetic, and she's asthmatic, and sore throat is not good news. So scenario one is where the GP practice is picking up this consultation. They go through it, and then they think that, okay, she needs a prescription. One, she might get an appointment to be seen because she's got asthma. Or two, she might be seen online if her asthma is controlled and the GP thinks that this patient needs a prescription. She might be eligible for an antibiotic depending on what her symptoms were. And if she went to a GP community pharmacy with the antibiotic, the pharmacist would dispense the antibiotic, but it would be more a transactional meeting for them. So they're going to go there. She was going to give the prescription for the antibiotics. Pharmacist will dispense it, give them all the instructions about the use of the antibiotic, and the patient would go away. That is scenario 1. Scenario 2 is kind of the scenario that Rita was talking earlier about and Ricky was talking about, where the patient don't just get one thing. They might have other valuable little nuggets they get from the pharmacy. So the GP in this case looks at this patient and says that they might be eligible for pharmacy first and then send them to pharmacy. The patient goes to the pharmacy and the pharmacist, while speaking to them, realizes that they're on inhalers as well. And it happens that they have a steroid inhaler as well. So the pharmacist not only kind of gives them the prescription medication if they require that as the antibiotic, but also has a conversation about the steroid inhaler and if they goggle their mouth after use of the steroid inhaler, because it might be that when they're using it continuously, it's hitting the back of their throat and making it more vulnerable to sore throats. So this is a seamless way of working where the patient is benefited the most from this kind of model where the GP practice has sent them to a pharmacy and they have picked up a condition where they are able to deal with and also add on value to that conversation or consultation. Next slide, please. Thank you. So this is, I used the slide in another PCN or practice in Daventry, and I was telling the staff there as well. I was looking for pictures for looking at reception pictures and for GP practice, community pharmacy pictures, and most of the ones which I saw were like really happy ones where the reception staff were smiling or the pharmacy was so happy and overjoyed to be with the patient. But I intentionally picked these 2 slides where the reception staff was really busy, stressed, answering their calls, and the pharmacy is busy as well. Both these settings are busy settings, and what I have captured there is what the patient thinks about those settings. So you in the reception as a care navigator are the first person they can contact to get some help. They like to talk about their condition, and they know that you would ask them more questions, and they know that you would signpost them to the right care as well. You are very skilled in terms of your customer service, your administration, and you would direct them to the right care. You are multitasking, and you are here to help them. Similarly, the pharmacy setting is where they have all the knowledge of the medicines and prescriptions. They know the patient as well, because the patient usually pick the pharmacy they would like to go to. You're going to make things better for them, and they do various other services, blood pressure check service. They look at your history of any long-term conditions, and they make a decision based on that, and they're here to help. So it's about educating and changing patient behaviors, like Rita mentioned, to reach out to the right place and the right setting. And from what Rita and Olivia mentioned, footfall to the practice reduces slowly over time due to learned behavior. And that can only happen when all the settings in NHS make sure that the patients refer to the same pathway every time they approach them. Next slide, Olivia.
Thank you, Minnie. So I just wanted to go and show some of our data for locally for Northamptonshire. So this is just a snapshot of our data from January of 2024 until December. And you can see that we've sort of had a couple of like peaks and troughs. So in February, that was when it sort of had the highest number with the launch of the service of the 31st of Jan. So that's like a sort of head start while everyone's sort of going in and trying to get as many as they can. And we've had a little bit of a dip, but as you can see, we're sort of slowly increasing our referrals between Northamptonshire. So it's just to sort of have a look to see all these little nuggets and all these little all these referrals that you're making, they do all add up. And for when you're just sort of there in your day-to-day role, you might just feel like you're doing one or two, but this all adds up into the bigger picture for Northamptonshire. And again, this is just a bit of a snapshot. So this is showing from April of 2024 to December. And it's just showing here that just over 39,000 referrals for pharmacy first have been made in that time. And that equates to over 6,000 hours saved. So nearly 7,000 hours of hours have been saved. And that equates to 7 full-time clinicians. So again, it's just looking at that bigger picture of all these referrals, these 1 or 2 referrals you may be completing daily, and how that all adds up into the bigger picture. I think it's just quite a nice snapshot. I know it's quite a busy slide, but just mainly these bits here, it's good to see sort of how that affects. So there's quite a number of resources, and I know we've sort of discussed that throughout the presentation. So on the left, that's a poster that has been created and sent out to all your practices. So you should have received this within the post. But if you're not aware that you've received it or not, or if you're certain that you're not, if you can just reach out to us and we can send the PDF copy of that. And then on the right, we've also got the primary care portal, and this is where we host all our information for practices to sort of tap into. So that will include the training videos for System 1 and EMIS, which we've talked about and we've not showed today, but that's the sort of step-by-step guides. We'll have the posters, we'll have the green and red inclusion exclusion posters that Rita spoke about earlier. So that's going to sort of host everything. So it'll be a really good tool just to tap into for any sort of new starters, or if you're just sort of re-looking into this service as a helpful reminder. So the link will all be sent out with these slides. Alongside that, we've also got campaign resources. So these are resources that the regional team have created, the national team and Community Pharmacy England have created as well. So there's an array of different things. There's social media packages, there's toolkits. So there's things, again, such as posters, different things can go onto your screens if you've got screens in your waiting room. There's a couple of videos that has been done as well by a local GP, a local Northamptonshire GP, which is worth watching as well. So it's just to sort of make you aware that this is something that is a national thing, and this isn't just something specific to Northamptonshire or to your practice. This is happening across the county and cross country as well. So all these resources will be shared with you to have a look at another date. So I'm just going to hand you back to Minnie to discuss the second and third bits, which we brought at the beginning.
Oh dear. Shreya, you're not using internet, right?
Is your internet working okay, Minnie, or did you want to? Is your internet working?
Can you hear me, Ola?
Yeah, we can hear you. It's a bit echoey, but we can hear you. Yeah, a bit echoey, but we can hear you.
Okay. I mean, I'm not able to operate my audio or video, but I think it's my internet. But if you can hear me, I'll continue. Can you hear me?
Yeah, that's worked a bit better with your camera off, Minnie.
Oh, thank you. I'll go through, I think in the beginning when we talked about the services that are linked with primary care access and recovery program, we talked about 3 services. One was the pharmacy first, which we talked about all this while. The other one is the blood pressure check service. So this service is expected to identify patients who are undiagnosed with blood pressure. And we've got brilliant sign up in Northamptonshire. We've got 117 out of 123 pharmacies who are delivering this service. Please check with your pharmacist if they are as well. As part of the NHS England specification, pharmacies can only pick patients with certain criteria, that is those over 40 years, not previously having hypertension, and who haven't got a blood pressure measured by any healthcare professionals in the last 6 months. However, there's nothing stopping general practice to make any referrals to pharmacy. So general practice can pick up any of their cough indicators which require blood pressure check, including ABPM for diagnosing blood pressure. So we know a few practices, what they've done is done a system one search to identify patients who've probably had one very high blood pressure reading, but not a diagnosis of blood pressure, made a list of those patients and then emailed it to their pharmacy to say that these are the patients we would like you to check ABPM, or this is part of a cough indicator for a certain condition like mental health drugs or any of the other conditions. Can you do their annual blood pressure check going forward for these patients, and send that as an nhs.net email to the pharmacy. Once you do that, the pharmacist can do the necessary checks, even if they don't fall within those opportunistic criteria, because general practice can make those referrals. So I would suggest that if you have a pharmacist, PCN pharmacist or a practice pharmacist working in your practice, have a chat with them about this, and probably it would benefit you to make these referrals to community pharmacy, because they can see these patients. Also, if you have your GP Connect update record switched on, these consultations will be coming back as automatic structured messages, which you just have to click submit or accept to get it into the patient record. It won't be like a flat PDF pack, which you have to sit and scan and read and spend a lot of your admin resources. There is also NHS website postcode search tool, which you can use. But obviously, if we are working how we propose that PCN and practices form neighborhood groups, we could use it. Or you could use this link and post it on your website, your practice website, if you want to make sure that patients who are not diagnosed, they can go to the pharmacy close to whichever postcode location they are, and they can access these free blood pressure checks if they don't fall within if they fall within those criteria. Speak to your local pharmacy. That's a message. Next slide, please, Olivia. The third service we would like to focus on is the expansion of the contraception service. Initially, when it was launched 2 years ago, it was just pharmacies were just able to order repeat prescriptions of contraception initiated by GP practices. Now, as part of this expansion from January, pharmacies are able to initiate oral contraception and also order the repeat prescriptions for them, including doing their annual check or annual review as well. So this is one cohort of patients you could easily direct to the pharmacy to do this service, and use your probably practice resource for contraception services for doing something else which is more needed for your practice. So again, there are a lot of pharmacies who do this. It's not as extensive as Pharmacy First, but the LPC, Rita and team are doing a lot of training so that more and more pharmacies sign up to this. There is a website postcode search tool. As a practice, you could use that tool, put your practice postcode in, and you would know who the nearest community pharmacies are who deliver this service. So again, speak to your local pharmacist and your teams, and probably work out a plan how you can signpost patients and reduce footfall. So you shouldn't be having patients coming to you for oral contraception into the practice. They could just go to the pharmacy, and it's probably exceptional that if they had to come into your practice. So yeah, utilize it's basically the message is, please do utilize these services that are available. I think that's about it, Olivia.
Thank you, Minnie. So I'll just come in on this point here. So we've created an MS Teams form for practices or community pharmacies to complete to feedback any sort of queries or issues that you have been facing. So as we've sort of said throughout the slides, myself, Minnie, Rita and team have been working closely with practices and pharmacies, but obviously there's going to be times where things might pop up. So we've created an MS Teams form, which the link and the QR code's there. So if you have any sort of questions or queries that you need to sort of go through, you can complete that. We do ask if you can put as much detail as possible. So I know sometimes we hear a bit of noise that something's not potentially working. Well, if you can give us the detail of why that's not working, what's happened, the clear examples, that will help us, and we can sort of set up a meeting with yourselves one-to-one to sort of iron out those issues. But all the slides will be shared afterwards, so you can have access to that. So we've just put our contact information here. So we've got Minnie, Rita and myself and our emails. And then on the right hand side, we've also put a QR code, and I'm just going to send this in the chat. And this is just for today's session. So if you don't mind just completing this quick MS Teams form, either scan it from your phone or click on the link that's in the chat, and that's just to sort of say how today's session's gone. So has it covered everything that you were expecting? Was there anything that was missing? And just your honest feedback will really support us moving forward when we do any more training sessions. So we'll appreciate any constructive feedback, would be great. And then lastly, any questions? So has anyone got any queries or questions? We've obviously got myself, Minnie and Rita, and I don't know if Ricky's still on there, but if not, we can take that away. But if anyone feels free to put, I know the chat's been quite live throughout the whole session and Minnie's been actively answering your questions, but if anyone's got anything else that they feel comfortable either putting in the chat or putting your hand up, please do. But if not, like I said, we have put our contact information there, so if you did want to contact us after the session, please feel free to.
Recording problem again?
Oh yeah, always.
Yeah, I've just gone back a slide. Hopefully that QR code's working. If not, I will unshare and try resend it again.
Yeah, I think the link said something's wrong. It didn't work for me, but hopefully the QR code is working. There's a bit of an echo.
Olivia, I think I know what the problem is with the Microsoft form. I don't think you've enabled anyone can answer in the settings.
I'll look at that. Thank you.
Yeah.
I'll unshare now and edit that because that should do it live.
Yeah.
Did anybody want to raise your hand for any questions? We've got a couple of minutes. We can try our best.
There's one question that has been asked a couple of times. It's just, can referrals be made from urgent care?
Yes. So I asked if it was co-op urgent care, and I've just seen the message. It says yes from co-op urgent care. From what I've heard, co-op urgent care have not enabled farm referral. I'm working with Lysander, the clinical lead, and your lead for nursing as well to start the process via pharma. Because you use system 1, if you can use I'm not sure you have the Arden template, but if you can make email referrals, you can still make email referrals. You should be able to access the community pharmacy details through there. But yes, Kobe Urgent Care should be able to, and I am working with Lysander and Mandy to make sure the team are up to speed on how to do this. It will be, I've just heard, will it be email referrals? It'll be email referrals for the time being now, because we are trying to onboard them onto PharmRefer. So once we onboard them to PharmRefer, it will be via PharmRefer. I don't know if people heard that. My system was blinking.
That come through me, it was fine for me.
Okay, thank you. I can't see any hands up. It looks like we might have answered some questions, but definitely we'll collate some of the questions from here and also from the MS forms you complete in the feedback, because there's a little bit about anything else you would like us to know, and we will get back to you. And Rita, did you want to conclude, or Olivia, one of you?
I think there's a hand up.
Oh, sorry.
I can't.
Okay.
Do you want to come in? If you can come in, is it Beth?
Beth, I think you might be muted, so you can unmute yourself. I think the whole thing is frozen.
Beth's put her question into the chat. That's, what do we do if a pharmacy sends something back that is urgent, but the GP deems it not urgent? Can we respond to the pharmacy and refer them back?
So the pharmacist thinks it's urgent, must be seen the same day, but the GP thinks it's not urgent. Then it's up to the GP practice how they want to deal with it. The pharmacist is doing the right thing by not telling the patient to go back and make another online online platform request for an appointment. But if the GP practice thinks that it's not urgent and they would like to see the patient at a later time and want to make arrangements for that, that's absolutely fine. It's up to the GP. If urgent, I think Becky's typing, if urgent, then it should be care navigated back to the GP from the pharmacy, next day triage. There you go. Becky's got the answer. Becky's been really helpful throughout the process. Thank you, Becky. I think we worked our pilot with Becky and she's been like a super duper PCN manager. No worries. Thank you.
Thank you.
Thanks. We'll share the slides out with our contact details if there's any other questions or anything that anyone wants to go through. And like I said, the MS Teams form will also be shared, so you can share anything specific to your practice or PCN, and we can contact you directly to work